So we know that staffing is important. So 47% of the entire NHS budget is spent on staff, accounting for over £56 billion every year. And it's important that skilled staff are available at the right time and at the right place to contribute to safer care and improve the care experience. But we know there's variation in how maternity services are staffed across the UK. And this includes not just the staffing levels, but also the composition of the workforce, how they're organised and how they're deployed. And this variation may be warranted by differences in the populations and the services. We know that anecdotal evidence of unsafe staffing is not sufficient to bring about a change in policy, but staffing decisions should be carefully planned and based on evidence, which is where my research comes in to try and fill some of this gap and expand the evidence base, especially in postnatal care. For now, we don't have a mandated ward level staffing ratio or minimum levels in maternity services in England, other than the requirement for one-to-one care in labour. In England, we ask healthcare providers to deploy sufficient staff to provide safe and effective care. And this is enshrined in the NHS Constitution and monitored by the Care Quality Commission. So first, we need to define quality. And this definition comes from the World Health Organization in 2018. And the three main dimensions describe care that's effective, so it's of clear benefit, it's safe, avoiding harm, and provides a positive experience. Person-centred care responds to individuals' preferences, needs, and values. The first two completed studies looked at the experience of postnatal care in mothers in 2018 and 19. And for those studies, I was able to download individual responses to the maternity survey and looked at whether mothers on postnatal wards had delays in their discharge, whether they were helped when they needed it, whether they had the information and explanations they needed, and whether they were treated with kindness and understanding. And I matched this to staffing data for the same time period. And I chose postnatal care because this is an area of dissatisfaction among mothers and an area where staffing can be variable. I found in those studies that trusts with higher levels of maternity assistants and registered midwives had higher rates of women saying they had a positive experience of postnatal care. Next, I went on to choose to look at postnatal readmissions. So readmission rates are currently 3.3% in England and Wales. That's maternal readmissions. And I found just two studies in the international literature on postnatal readmissions in relation to staffing. So readmissions and why they matter. I also chose to look at them because they're well recorded in hospital systems and they're a useful marker of care. They matter because they're costly in terms of finance and women's experiences. In terms of finance, there's the cost per bed day, the cost of staffing, the cost of treatment, and the increased service activity. And for women and families, there's disruption, additional treatment, separation from their family, stress, impact on bonding and infant feeding, additional travel and separation from their other children. So these are the methods that I used. I completed a secondary analysis of a large longitudinal study, and this involved 64,250 postnatal mothers who gave birth between 2015 and 2020 in 3 hospital trusts in England. I was able to access anonymised individual patient data, and this showed whether the individual women were exposed to understaffing during the first 2 shifts of their stay. I was then able to screen the data to see if they were readmitted within 7 days, within 30 days, or they were not readmitted at all. And I was able to account for some of the other factors that can make a difference in readmission, other than staffing. So I was able to account for the mother's age and the type of birth. And I was also able to look at service level factors like how busy the unit was for admissions and discharges, and the staff composition of midwives and support workers. And to calculate understaffing, I compared this to the average level for the unit. And here are the results. So within the 3 services over the time period, 2,903 mothers were readmitted within 30 days of discharge. So that's 4.5%. And of these, most of them were readmitted within the first 7 days. I found that below average midwifery staffing was associated with higher rates of postnatal readmissions at 7 days of discharge. This was an 11% increase and was statistically significant. The effect was smaller when I looked at 30 days of discharge. It was an 8% increase and not statistically significant. So this was for the registered midwives, but there was no clear relationship with the maternity assistants understaffing and readmission rates. The most common reason for readmission was infection of any type, followed by bleeding. And the rates of readmission varied by the method of birth, as you might expect. I wasn't able to look at the potential mechanisms by which understaffing could lead to readmission, but we could speculate these to be potentially rushed care, poor discharge information, perhaps some were discharged too early before their complications were noted. There could be less breastfeeding support than is ideal, potentially leading to mastitis, the potential for insufficient wound care or monitoring, possibly signs of deterioration could have been overlooked, or there could be poor communication with the community teams or an incomplete handover. So that list is speculative, but trying to think about how they could be linked, these two things. And my final study is about safety incidents. So in many systems, they're called DATEX, so DATEX incidents. And I looked at how many of these occurred in relation to the staffing levels on the very same day in maternity services. And these incidents included maternal and neonatal deaths, stillbirth, labour events such as hemorrhage and perineal tear, discharge incidents and medicines errors. It's important to learn from these events and think about the contributing factors. So this study was not just in postnatal care, it was across the service. It's always difficult to estimate the true extent of incidents because they do rely on staff reporting, and we know that staff don't always have time to report their DATEX incidents, so we need to bear that in mind. So this builds on a scoping review that I did in 2020, which had quite mixed results. So on the left-hand side of the line were all the studies that showed or indicated that having understaffing was linked with poorer outcomes to the left of the line, and those to the right of the line showed effects that were either no difference or effects in the opposite direction. So this really led me to the aim of this study, to look at the midwifery staffing and the rates of incident reports on a daily basis. So this is more detailed than has been studied before. The methods I used for this study were very similar to the other study in that I accessed secondary data, but I was able to use staff rosters and the details of patients' submissions, discharges and outcomes for 2015 to 2020. And the total was almost 107,000 admissions. I was able to look at staffing information from the roster, and I converted this to hours per patient day, which is made up of the total worked seconds for staff members and the total occupancy time for mothers and babies. And then I accessed the daily reported incidents. And the main outcome was any incident graded as harmful to patients. I was also able to account for other things happening on those days. So the age of the women present, how many of them had medical conditions or comorbidities, whether it was a weekend or a weekday, and also the pace of the service in terms of how many people were admitted and discharged. And the results are summarised very briefly here, but I found that the actual staffing levels varied between the 3 organisations. And also the harm incidents varied between them, from 2.1 per 100 admissions to 3.0 per 100 admissions. In the purple block, we can see the results which showed that understaffing by registered midwives was associated with an 11% increase in harm incidents, and this was statistically significant. In the black block, I show that understaffing my maternity assistants was not associated with an increase in harm incidents, so there was no relationship there. And in the green block, I found that higher patient turnover, so admissions and discharges, was associated with a 19% increase in the risk of harm incidents, and this was statistically significant. This had not really been looked at before, so it was a surprise finding, but quite stark. So these results tell us that the days when there are fewer midwives or higher numbers of admissions and discharges are associated with greater harm to mothers and babies. Many of you won't be surprised by this. I went on to look at specific types of incidents and the coefficients, so the numbers show how the rates of incidents change, and the numbers in brackets are the confidence intervals, which show us how certain we are about the estimate. The result at the bottom in red shows that staff were actually reporting low staffing and high workload. They reported these as incidents in themselves, and I found that their reporting was associated with actual low staffing. So the numbers that I calculated for the midwives' hours were very much related to when the midwife said that they were running short. So that would be expected, but it was reassuring to see that those things tallied. Many of the estimates are above 1, suggesting that the specific incidents occurred more often when maternity services were understaffed. Many of these were not statistically significant, but the biggest effects seem to be in delays in care and discharge incidents. The results when we looked at maternity assistants were mixed. There was no really clear effect going on there. Then I looked again at patient turnover, so the number of admissions and discharges, and this seemed to be really clearly linked to specific incidents. So a 51% increase in discharge incidents and a 22% increase in rates of delayed care when there are more people being admitted and discharged than normal. So here are the conclusions from this study really, is that I was able to find an association between the understaffing of registered midwives and incidents involving patient harm. So the implications of this are to continue to invest highly in registered staff and to continue safeguards on understaffed shifts. I saw that high turnover was associated with higher reports of harm incidents and other incidents. So the implication could be to adjust staffing where we're predicting a high turnover of patients, if that's possible, and to offer support to mitigate risk. One approach could be to set the baseline staffing slightly higher, so we're able to deal with these variations, such as peak demand. This research is not able to tell us what the safe staffing level is or recommend an optimal level. However, the use of routinely collected data in future could help us to do this using mathematical models. But this study does help us identify the effects and provides justification for the prioritisation of staffing. So just to highlight the papers that I've discussed today, and these are available on your resources. And finally, a plea for some help, please, is that I'm planning future work using large NHS data sets to look at the workload of midwives in current NHS settings and how this fluctuates from shift to shift and week to week. I'm keen to understand more about the workload itself, perhaps how much of this is predictable and unpredictable. And by understanding this better, it may be possible to smooth out some of the workload or plan for this better. I am in an early stage of this research proposal, but I would love some practitioners, managers, service users to guide me with their thoughts so we can make and design the best possible research. It might also be useful to link with digital midwives so we can see what we can extract from the data rather than collecting new data. So if anyone on the call is interested in a short chat or email correspondence about this, I would love to hear from you. And my email address is on the next slide. Thank you.